In the last couple of years, his health care has declined. He's been hospitalized multiple times, and he said that was the last time he wanted to be hospitalized. As long as they can have a conversation about it. It was an easy conversation in the hospital where the son says, I just don't want my dad to die. That's an easy conversation, because then you just talk them through that. But if they can give a thoughtful description of why we're not going to follow the advance directives, then yes, we would go with the agent. So it's definitely all a thoughtful discussion at the bedside. Yeah.
What's the kind of current thinking? Like the family says to you, "What? I don't know. What would you do if it's your mom?"
Yeah.
What do you then like? Is it okay to say, "If it was my mom, I wouldn't intubate her," or do you not be that blunt with them?
No. So I guess it depends on how blunt. And I think you get the sense from your patients and your family members. He's asking if you're ever blunt. If someone says, "What would you do if it's your mother?" What would you do? And I definitely. It depends on sort of the scenario of. Is this end-stage malignancy or, antibiotics? I'm not sure, but it's very different. But I do think it's okay to give your opinion, but your opinion, I think, should be based on what you're eliciting about your mom. So what I might say is, well, tell me more about your mom, as opposed to saying what I would do for my mom. And oftentimes they'll say, well, my mom is different from your mom, so tell me more about your mother. So sometimes they'll ask you what your opinion is. Your medical opinion is really your opinion, right? So. And it's what you would do for your mom, usually. All right. Thank you.
The few things that still has the potential to really get people's heart rates up. Most problems, I think, get common enough, you get comfortable enough that your pulse stays relatively constant no matter how stressful the situation is for everyone else. I think a difficult airway or the prospect of one along with sort of a sick kid, is probably the exception to that. And on top of that, everyone else can feel that. And everyone else is losing their minds. And ultimately, it is on you to remain calm and be able to navigate the situation as easily as possible. And what I want to do is talk a little bit about how airway ultrasound can help you do that, both for the intubation and in the peri-intubation period. And I will fully acknowledge that this is, or at least I hope it is the case, that this is not an everyday event. This is something that you are going to use selectively in those sort of high-risk, high heart rate situations that are ultimately the reason that we're there. So there are three things that I want to cover. The first is how we can use ultrasound to help identify landmarks for a surgical airway and do a better job with that. Second, the role of how airway ultrasound can help us pick up an esophageal intubation sooner. And then finally, how we can use it to help optimize tube position. The first, identifying cricothyroid landmarks. So we all know what our sort of target is going to be in the event that we have to go to a surgical airway. We're looking for the cricothyroid membrane. But we are terrible at identifying that. And if you think you're the exception to that rule, you are from Lake Wobegon, where everyone is above average, and you are the driver who thinks that you're better than average for everyone else. And we know that that is not true, and there's data that supports that. We'll take a look at it. But understand that we don't do a great job of figuring out where that cricothyroid membrane is. I'm sure that many of you have done or seen or been party to a cricothyrotomy. And if you think back to what that felt like and how that went, it almost never goes well. It never feels comfortable. And airway ultrasound affords the opportunity to make it a little less comfortable. The idea here is that in a projected difficult airway, you can use ultrasound to figure out where your landmarks are before you go ahead and cut. This is not a tool that you would use in the situation where the patient has crashed and you just need to try and establish an airway. This is someone who you have the time where you project that it may be difficult. Maybe it's the 300-pound COPDer who's tiring and you're getting to the point where you think, I gotta go ahead and intubate them. That's the time that you want to use this. Use a high-frequency transducer, and this is the kind of image that you might generate. It does make sense to play around with this. A little finicky. If you're not an experienced ultrasound user, come to a course, learn how to use it. Even if you're not, you can play with your ultrasound machine, assuming you've got one in your department, and understand what this looks like on yourself before you have to go try and do it on a patient. But this is a representative image of what you might see. One of the first things that you want to try and pick up is where are the tracheal rings. Those are those relatively hypoechoic or dark sort of string of pearls-like structure that sits on top of a bright white or hyperechoic line, which is the air-mucosal interface. You can try and recognize the landmarks anatomically with your hands. and go and put the ultrasound on and see what you find. And those are the first things you're going to let your eyes go towards. And we'll practice this in a second. As we come to the cephalad end of that string of pearls here, just above it there's a slightly bigger structure. And that's the cricoid cartilage. A little bit more cephalad to that, you've got the thyroid cartilage. In between it sits your target. That's the cricoid thyroid membrane. That's what you're looking for. And when you see this on ultrasound, you realize what a small target it is. It's a tiny little thing we're looking for. Let's take a look at a couple other examples. Again, a linear transducer, the high-frequency transducer that's good for superficial structures. There's the thyroid cartilage. There's the cricoid. And there's the cricoid thyroid membrane sitting on that bright hyperechoic air mucosal interface. Take a look at another example here. And we're going to look for kind of that bright white hyperechoic air mucosal interface, the tracheal rings, and the cricoid and thyroid cartilage. There's the interface, a couple tracheal rings, just cephalad to that, the cricoid cartilage. There's your thyroid, and there's your target. It makes sense to practice this, and hopefully you will never need to use this. It is certainly not a regular occurrence. I probably do this about once or twice a year, and ever since I got ultrasound training, I've never actually had to do a cricothyroidectomy. They were all pre-ultrasound use. But it affords you a little bit more confidence to understand where the anatomy is when you're preparing for a double setup, a projected difficult airway. Let's take a look at a video. It's a little dark here, but again, the air mucosal interface stands out. And then you take a Sharpie, whatever your marking pen is, and make your mark. And hopefully, you never have to cut, and you never have to use this. But understand, it will make you better if you do. Why is that so? Well, there's pretty good data, primarily from cadavers. This is a hard thing to study prospectively, as you might imagine, that shows that this helps us do a better job. Here's cricothyroid membrane in live patients by anesthesiologists and surgeons. Let's, for the sake of argument, assume that we're no better than them. Okay? When you look at who correctly identified the cricothyroid membrane, when you go back and take a look with ultrasound, you see that they were not so good. And there's no reason to believe that we're any better than that. Okay? That's abysmal performance. And there's no difference there when it comes to experience and how long you've been doing this. This is a cadaver study of patients with difficult neck anatomy. So that prototypical COPD who's tiring, who's 300 pounds, you're not looking forward to going to have to intubate. And then they asked essentially, how well do we do in terms of, one, identifying the correct landmarks, and then two, when you actually go and perform a cric on the cadaver, how good was your procedure? Did you cause any injury to the surrounding structures? And you can see that palpation, terrible, a little bit better with ultrasound. There's a long list of procedures I hope never to need. Cricothyroidomy is at or near the top. But if I do need one, please use ultrasound to help figure out where to cut first. Then when you look at larynx or trachea injury, again, you see better performance if you take a moment to go and use ultrasound first. They were a little bit slower with ultrasound, in the order of 25 to 30 seconds. You might argue that that's a trade-off you don't want to make. But I think the success rate and improved location in a high-stress, high-heart rate scenario make it worth it. You want to go ahead and do this in high-risk airways. All right, second thing you can use airway ultrasound for, the ability to recognize an esophageal intubation sooner. And this primarily applies if you supervise other people. If you're the operator and placing the tube, you know yourself whether you saw the cords and how confident you are they actually put it in the right spot. But if you supervise trainees or learners, or you're helping out a colleague during an intubation, this is one more tool you can deploy to help recognize sooner if you put the tube in the right place. You can use either a high-frequency transducer, the linear one, or an abdominal transducer, the sort of curved surface, with lower frequency that actually looks a little bit deeper in patients who may have larger neck anatomy. The technique here is that you're going to place the transducer in a horizontal plane, about just on the anterior neck there, like this, just below the thyroid cartilage. And then you're going to slide off laterally a bit. That will generate an image that looks like this. The major thing that you're looking for first is to try and pick up the trachea. This is a structure that has a lot of shadowing behind it. So you're going to see a bright white signature and then a shadow with nothing behind it because it's just air. That's what we're seeing here. Adjacent to that, you're going to look for a bright white line or hyperechoic line that corresponds to the vertebral body, which is sitting right there. Just anterior to that is where you'd expect to see the esophagus. Let's see how this looks in a live patient. And this, unfortunately, is projecting a little bit dark, but you can still see the signature of the esophagus here. So the first thing you want to look for is, do you see the trachea? There's the trachea here. Vertebral body's right there. And that's the area of the esophagus. And you see a winking signal there, that sort of flash. That's someone swallowing and training air into the esophagus. So the way this works is it's a real-time technique. So the proceduralist is going ahead to intubate. You put the probe on the neck, as we just saw there, and then you go ahead and look and you ask, have I put the tube in the esophagus? The way that you can tell is that if it goes into the goose, you'll see the esophagus light up. And again, this makes sense if you're working with trainees or learners and you're supervising the intubation. Here's an example of an intubation attempt. You tell me if they put the tube in the right spot. Is the tube in the esophagus? Yes or no? Hands up to say yes. Bunch of hands for yes. Okay, so there's the trachea, bright white signal with a shadow deep to it on the screen. There's the vertebral body right there. And then intermittently, right above it, you see something wink into view. That's your signal that someone has placed the tube in the esophagus. If you have access to video laryngoscopy, this may not make sense. If you don't, which is my experience for much of my career, then this is a nice adjunct if you're supervising someone else through an intubation and you can get real confirmation of where they're putting the tube. Here's another intubation attempt. Answer for yourself whether you think it's in the right spot. So look for those structures. First we're going to look for the bright white line of the trachea with a shadow, or sort of empty space behind it. Then we're going to look for the vertebral body, and then we're going to see if we see a signature that looks like something popping into the esophagus. There's the trachea. This is the area we're looking for the tube. And you don't see anything jump into view in the same way that we did with the other intubation attempt. This is a sign that you've put it in the right spot. You shouldn't see anything if an intubation attempt is successful and correctly placed in the airway. This actually works pretty well. At a meta-analysis level, you can see that the test performance characteristics of using Airway Ultrasound to help determine if you put the tube in the right spot are pretty good. Again, if you practice independently, if you don't have trainees, this may not make sense. But even if you're working double coverage and it's a potentially difficult airway, this is another thing that you can potentially use to try and help recognize an esophageal intubation a little bit earlier and avoid hypoxia and do better for the patient. The final thing that you can do is use ultrasound to help figure out where you've actually positioned the tube, try and do a better job with that. The basic idea here is that we're going to take advantage of some of the properties of lung ultrasound to help determine where we put it. Use the high frequency transducer, place it on the anterior chest, and what we're going to be looking for is lung sliding. That's the sort of shimmery effect that you see on the pleura, right here. Sometimes described as sort of ants marching or a shimmering effect. That's a sign that the pleura are in contact. If you see that that lung sliding is present when a patient is being ventilated after intubation, you can be confident that you're getting air and that you're ventilating the backside of the lung. So here's an example of a patient who's just been intubated. On the right, you can see that shimmering from the lung sliding. On the left, you also see a shimmering effect, but you notice that it's a little bit different. It's faster. It's not at the 12 or 14 breaths per minute that they're being ventilated at, and it has a sort of a pulsation to it. There's the lung sliding. This phenomenon is called lung pulse. So that's a situation where you have the pleura in contact with each other, and they are moving, but it's not with ventilation. That's the heartbeat being transmitted through the lung up to the pleura, and you're seeing the pulsation effect from the heartbeat. When you see this on the left side, but not on the right, where you have normal lung sliding, that's your sign that you've right main stemmed the patient. Okay? You can draw the tube back. You're not going to wait 20 minutes for your x-ray for the radiologist to tell you that you've put it in the wrong place. So you can just withdraw it to the point where you're actually visualizing lung sliding on both sides with ventilation. Nice little trick to help you put your tube in the right spot. The other thing you can do, and this works particularly well with kids, is if you want further confirmation of where you've placed the tube, is fill the cup with saline and look to see if you can visualize that. And that will help ensure that you've placed it at the right level. So here's an example of a patient whose cup is getting filled with saline. It happens right there. And the key thing that you're looking for here is a phenomenon called posterior acoustic enhancement. So when you introduce fluid into the cuff, that creates a medium that ultrasound can look through, so you can start to see deep to it. So this is a looped video of the cuff going up with saline. You can see right there that it gets a little bit brighter as it fills. And as we loop back through, you don't see that same signature. That's a sign that you've put it at the right level when you can visualize this as the cuff fills up. This technique is actually highly accurate, and it's particularly helpful for patients that are managed in the OR, where you're not necessarily getting a post-intubation chest x-ray. But it can still be applied to the ED setting, and it's another tool that you can use to help figure out if you've put the tube at the right level before you wade through the chest x-ray that can go in place. Those are the three things. Not going to be an everyday occurrence, but in the high stakes, high stress scenario of difficult airways or post-intubation hypoxia or uncertain placement, these can be a really nice adjunct and a nice help to figure out if you've put the tube in the right spot. Help you figure out the surgical airway landmarks. Hopefully you'll never need them, and help recognize esophageal intubation sooner. And with that, thank you. I'll take any questions. Great, thank you.
Peter and his ketogenic diet, I probably wouldn't be here today, so I appreciate that. We're going to change gears a little bit and talk about burns. I'm an ultrasound guy, so this was kind of fun for me to do a topic other than ultrasound because I get a little tired of talking sonographic waves all the time. So we're going to discuss burns and hopefully give you some pointers to move forward and to take to your shops. So I tried to package this into a way that kind of hits the cornerstones of burn management for emergency providers. The way I've done this is to kind of break it into this bit of a mnemonic. I'm not a huge mnemonic person, I use it for shock, but this I think is somewhat helpful. The first of which is going to be fluids, is this a hot button topic in most burn patients and most burn management styles. Next is evaluation, and that's the evaluation that we're going to be doing initially when the patient runs through the door or is rolled through the door in our emergency department. Next is environment. So not only the patient's environment that they came from and kind of understanding and trying to grasp where they're coming from, but also the environment that you're controlling in your emergency department. And lastly is a few tidbits on logistics, especially for folks that are going to be senders of patients, which I guess is probably going to be the grand majority of us. None of us are working at big burn centers. So just a few things on logistics too. So those four things kind of develop the cornerstone what I like to think about in terms of burn management. Let's start with the first E, evaluation. So a little bit like drop, stop, and roll, or drop and roll is this bit of a stepwise progression for your initial evaluation. First off, you need to strip your patients down. This can be fraught with some pain. If you've ever done this for someone who's had a significant burn and their clothes become adherent to their skin, you need to take extra care that you're cutting around those areas, especially when you're trying to take their clothes off. Because if you ever try to rip that, I know I've done that when I was early on in my career, it's extremely painful. So really strip down the patient all the way through, look at their back. The other thing you need to consider is sometimes these patients are coming from areas where there's been minor explosions, so they could have some shrapnel or metal in their body, so you need to look at every part of their skin. So strip them down. Next off is flip the patient. We're always taught burn patients are like trauma patients. Take heed of the neck. All right, so these patients are often coming from areas where their roofs may be weakened, their floors may be weakened, they may have suffered a fall. Sometimes they're jumping out of windows to get out of the scene, and they present to you not really being able to localize much in terms of pain and discomfort. So make sure you flip the patient and think about their neck and take care of their neck, and make sure you mobilize their neck. The next thing flipping the patient can let you kind of accomplish and to think about, or at least for me, is burns that may be circumferential. Okay, in pediatrics, performing an aspirotomy doesn't always have to be circumferential, the way their dynamics are. But in adults, a circumferential burn can lead to decreased perfusion, compartment syndrome, and really, disastrous consequences for patients. So flipping the patient, for me, makes me think, let's look for burns that are circumferential on the body. If you've ever been in this situation, it is extremely unsettling. Have you guys ever been, let's show of hands, anybody's ever been involved in a chest aspirotomy? You probably can tell all of us the details of that case, right? This is one of those cases that are really poignant and sticks with you. We're not going to go into the details of how to do this. Hopefully you'll never have to do this. But if you ever do, the key to take home is to try to make axial cuts. This is especially true if you're ever doing it on the limbs of patients. You don't want to cut across nerves, cut across structures that are running down the body. So you want to make axial cuts, not transverse cuts. You're probably more likely going to be doing this for a limb than hopefully an entire chest. So axial cuts for escharotomies. Other things, hopefully the patient's intubated and sedated. You want to use hemostatic devices, things like the Bovi. We were using that in medical school and surgery. An awesome device, you can kind of cut right through tissue. Cut to fat, so once you see that adipose tissue coming up, you know you're in a good spot, so that's a good depth to go to. Go to the adipose tissue, then stop. And lastly, have a decreased threshold in pediatrics. This is really, really hard, right? This is something you don't want to have to ever do, especially in a child. But this is something you need to have a decreased threshold to do, especially if you're sending the patient hours in transport to a burn center. You want to do this before they lose pulses. You want to do this when they show signs of decreased perfusion. All right, so you have to have a decreased threshold to do it. This would be an exceedingly hard thing to have to do, but it might be the best thing for the patient. It might save their limb, especially in pediatrics. So let's strip and flip. Next is touch. And when I think about touching a patient with burns, I think, and I liken it to evaluating patients with rashes. So you need to touch a rash, you need to see if it blanches. You need to touch a rash, you need to see if it's painful. The same concepts apply to burns. So touch the burn, see if it blanches. It'll give you an idea of how deep that burn is. If it's sensate, is it insensate? It'll give you an idea of how painful the burn is. So make sure you use your tactile senses to go through your full evaluation of your burn patients. Each patient can present with a wide spectrum of burns, from first to second to third degree. Every single patient can have each of those types of burns. So take that into consideration when you're evaluating and touching the patient. We're not going to go into the rule of nines, but I will tell you that we stink at estimating body surface area burns. So a great study came out recently, 125 patients sent to a burn center from an ER. 25 of those patients had over 100% overestimation of their burn surface area. Not just a little bit, over 100% overestimation of their burn surface area. So we're really poor at doing this. And then you might not think that's a big deal, and it might not be a big deal, but if you're giving the patient fluids, which we do initially, and we probably don't do a great job of that either, if you're doing that at an estimate of over 100% of their burn, then they're getting 2 times, 3 times as much fluid as that they should be getting. And we won't see the consequences of that, but some of our ICU colleagues certainly will. Lastly, smell. And for such a cute picture, you know that the smell of a burn victim is pretty appalling and unsettling, and something that really sticks with you. When I was a resident at Maine Medical Center, the only smell that's exceeded the smell of burn victims is we had a patient, and Dr. Motley might remember this case, I'm not sure if he was there, but we had a patient that was brought in from Biddeford, and this guy, this is not a burn, but this guy was brought in from Biddeford, Maine, in the ambulance in a sofa because he was stuck in a sofa for 7 months. And someone was taking care of him and giving him food and giving him, they said there was like 27 up bottles scattered around the room, and EMS brought him in. So he was actually grown into the sofa, and he was septic. He ended up getting up to the ICU. His numbers were, talk about crazy numbers in terms of CK and lactate, but this guy had amazingly appalling numbers, and so that was the only stench that I can recall that outperforms a really bad burn. Because you could smell it in the whole hospital. It wasn't just located in the emergency department. You walked into the hospital, you could smell that for days. So use your sense of smell. I want to bring up smoke inhalation a bit. If patients present to you without exceedingly expansive burns, and they are showing signs of decreased mental perfusion, decreased sensorium, that should make you think of smoke inhalation. All right? Burns don't and shouldn't make you unconscious unless they're extensive. So if your patient's unconscious, you need to think of one, medical reasons, of course, but more higher on the list are smoke inhalation reasons. One is carbon monoxide, it's probably going to be the most common, and the next is going to be cyanide. And we probably underdiagnose this or underthink about this. Again, does it really matter? Do we have cyano kits that are at the ready at the bedside? Probably not. But the best way to diagnose, or at least to think about cyanide toxicity, in a patient without extensive burns with decreased sensorium, if their lactate is above 10, the chance that they're cyanide toxic is close to 90% in terms of sensitivity to specimens. So lactate greater than 10 in a patient without extensive burns with a decreased mental status, obtunded, and unconscious, those types of markers. So lactate can be a really good marker for you to think about cyanide toxicity. Again, what are you going to do? You're going to give them oxygen and potentially give them an antidote, but cyanide levels are not going to help you at the bedside. All right. So it's just something to think about. Do you guys remember how many people can smell almonds? My sense of smell is terrible. My pregnant wife right now can smell everything. But sensing almonds, or how often people sense almonds or can smell almonds, about 30%. So 3 out of 10 people can actually smell it. 7 out of 10 won't. Let's transition to something that smells really nice. So that of a barbecue in the summer, I went up right, I can smell that for a few months, especially up where we live in Maine and Vermont. Let's think about something that smells really nice and refreshing and makes you want to have a beer too. So I know that in Maine, I'm sure you guys see this too, but a lot of patients will present from barbecues or get-togethers with flash burns. So these guys will throw accelerant on a grill and it will pop up into their face. And it'll often be a very dramatic, frenzied, chaotic kind of presentation. They're screaming, they have a lot of facial issues going on, their pain control is paramount. But what I want you to remember on these patients is that almost none of these injuries will have an inhalational component. So these patients very, 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 very rarely will have to actually be intubated for this. Especially, I mean, you're looking at them, they're screaming, they have a lot of facial swelling and injury, but usually it does not affect the lungs and the posterior pharynx. So that's the take home. Usually flash injuries are so quick, boom, snap. Quick on, quick off, like a second or two, and it's not really going to have time to take effect to the mucosal membranes and lead to edema in the posterior pharynx. With these patients, you need to remember your bread and butter, right? Though you got to treat them like you would irrigate an eye. You got to look at their visual acuities. You need not to forget the corneal injuries, because these patients, a high percentage of them will have a corneal injury. So make sure you do that as well. While these patients won't need to be intubated, some patients coming from fires they're exposed to longer durations of warmth, longer durations of burn, longer durations of fires, will actually end up needing airway protection. And we can go over the singed airways, the soot on the face. From talking to trauma specialists, when I was preparing for this talk, the number one indicator, or the one physical exam finding to look for, is posterior pharynx. Posterior pharynx, posterior pharynx. If their posterior pharynx is in any way affected, meaning any swelling or seeing any voice change, that sort of thing, those are the patients that those patients will be prophylactically intubated. And they'll do that pretty early on. So singed eyebrows and such, those things can help, but focus your attention in your exam to the posterior pharynx on burn victims when you're trying to anticipate which ones you'll have to definitively manage their airway. Won't talk about this, but I would be bereft not to mention that you should consider using ultrasound in these patients in evaluating a spot to do a neck hyperthyroidomy, right? So these are patients that are going to have swollen necks, so their landmarks are going to be even more hard than some of our patients. So that's where the use of an ultrasound can really come in handy, and that's why Dave's talk, that's what I would use it in these certain circumstances, to try to identify your landmarks that you'll be shooting for. When I was a fourth-year resident at Maine Med in the ICU, we had a trauma surgeon who just retired, and we had extubated the patient who had suffered a burn, and the trauma surgeon left the department. Because this trauma surgery rotation as an ER resident is, and Brooks can tell you, is astounding. You are left at your own whim. You take care of the sickest of the sick, and oftentimes the trauma surgeons are not in-house. So this patient we had extubated. About an hour after extubating her, she became incredibly stridulous, and her SAT started to plummet. She got tachypnic. I had them page the trauma surgeon, and I went up to the head of the bed, and I asked him to get the advanced airway equipment and to try to start prepping for a neck incision. And when I looked in her pharynx, there was nothing. It was just pink, like just a big pink mess. And at that moment, the trauma surgeon came in and he said, "Can you do this?" And I said, I can't see anything. And I still remember to this day, no gloves, nothing, just grabbed a knife, sliced her throat and threw in a tube, and she walked out of the hospital 2 days later. And I remember thinking, if he wasn't there, thank God he was there. He's an old school guy, but he never would leave the hospital. A lot of the other trauma surgeons did. He never would leave the hospital. If he hadn't been there, I wish I could tell you I could have saved this lady's life, but as a third-year emergency resident, having never done one before, I don't know if I could have done it. So it kind of made this topic a little bit more topical for me personally. So that's our first E, evaluation. Strip, flip, touch, and smell. Next off, environment. And this is something that I mentioned a little bit before about controlling not only the patient or your environment, but also considering where the patient is coming from. You can't control the fire that happened, right? You can't control what happened. You can actually try to get a good history from the paramedics, from your EMTs, to find out, did the patient, were they found in the bedroom? Were they found in the kitchen? Were they found in the living room? These things sort of matter, especially when you're thinking about cyanide toxicity, combustion of rubbers, synthetic materials. Those things should go a little bit higher on the list. Was the patient found outside of a window? Did they jump away from the house? So really understanding not only your environment, but where the patient is coming from is really helpful. If you're not sweaty and uncomfortable, or your intern or your medical student doesn't have sweat on their scrubs, then you need to turn the heat up in the room. This is something that we don't do a good job of. This should be done before the patient arrives. It should be 90 degrees in your room. Why is that? Because patients that have severe burns are cold. They've lost that barrier of protection, that thermal barrier. So they're actually cold, right? So they don't have any protection mechanism. Despite the fact of being severely burned, they need a warm environment to do well. So turn the heat up. If you're not uncomfortable and sweaty, that means the room is too cold. So turn the heat up in your room. Another thing that you need to control and you need to think about is the patient's ability to prevent infection. They've lost that barrier from infection as well as that barrier from thermal regulation. So the topic of dressings, I know that this question comes up every time that we talk about this, is which one is good? Do we use sulfasilbidine? Do we use Acticoat? Do we use BioBrain? Do we use Zerofoam? I love Zerofoam, especially for partial thickness burns localized on parts of your body. Zerofoam is really, really effective. There is still a role for Silvadene dressings, and the trauma folks that I talk to say especially the really deep burns. So the 3rd degree, full thickness burns are the patients that you want to consider still using the Silvadene, especially if you're sending them away to another burn center. But the patient that comes in that put their hand on the stove and have a burn on their hand or on their arm, that's a patient that I would typically use Zerofoam. The key is to keep burns warm and dry. It doesn't really matter what you use. There's no literature that says one is exceedingly higher than the other at healing rates. But Zerofoam is quite helpful. Mobility of joints, mobility of fingers starts on day 1. Starts when you do your first dressing change. So for instance, if patients have burns in their hands, you need to dress every finger individually. If you dress their elbow or their knee, you need to consider mobility. And then if you talk to wound specialists and burn center specialists, they work on mobility right on the first visit. So use that example or use that logic when you're doing your first dressing in the emergency department. Think about mobility of joints and fingers. Another patient I had about a month ago came in from Wendy's, doing a fry-o-later, and put the fries in, and everything went up to the face. So it's kind of like a scalding injury. And we ended up giving ketamine to this patient pretty quickly when they arrived because of the degree of pain. And then the medical student was up at the bed, like fiddling with the patient. I was sitting there, I was like, what is she doing? And she was putting a dressing on the patient's, on the burns, which I should have thought of right off the bat. Just covering the skin that's burned will decrease the pain substantially. Sounds simple, and in that moment I should have thought of that, but I was thinking about other things, if we had to do airway stuff, blah, blah, blah. And the medical student just kind of hammered home just a nice simple point. If you do have a burn, cover it up quickly, and that will take a lot of that oxygen affecting the burn and the burn skin, that reaction that happens, that will mitigate some of that. So cover the skin pretty quickly on your first presentation. You can use cling wrap. I don't even know if we have that at Maine Medical Center. Nate's shaking his head, yes, so I think we have it. But you can use cling wrap, it's a nice adjunct, it's easy, it's simple, it's cheap. And don't forget to irrigate patients. We do it when they get foreign bodies in their eyes. We should be doing it with burns as well. You can do it up to 3 hours. All right, 3 hours of this. So, and I certainly don't do this. Don't use cold, ice cold water. Use just normal, tepid tap water is fine. All right. Seems like a far, far away from where we are today. So sunburns. You've seen sunburns before. If you've worked in an urgent care center, you have seen sunburns that come in, right? We all have that patient. We all have that patient that we think about that stayed in the sun too long, or that friend in high school. When I was in high school, I had a friend, this wasn't a great friend. He had a great house on the beach. So we went to his house, and we were underage, so we were not drinking. But the night before, we had a good time, and then the Saturday, we went out on the beach, and this kid had too much to drink, and he fell asleep for 4 hours on the beach. And he was a Irish kid, so not a lot of complexion. But he looked like this when we left that day. And needless to say, that the weekend of carousing and having fun was cut short. So what do you do when you see these patients? Again, not a life and death situation, but they often are very histrionic and dramatic. It's actually been shown, just use aloe. You don't have to think about anything else more fancy or sexy. Use aloe. It's been shown to help with wound closure, decrease scar formation. It's cheap, it's easy. Just have them go pick up a nice big bottle of green aloe at the Rite Aid or Osco and apply that generously for the next few days. Lastly, in terms of prevention of infection, what do we do with blisters? Right? Do we pop them or do we not pop them? Should you do it or should you not do it? Right? There's this big argument that happens. And if you look at there's a Cochrane review, like 127 articles, and it's a nice review, and they go through it just at tedium about what patients work best, what patients don't. I'm going to make it easy for you. In the ER, just don't pop them. All right. The blisters themselves will house some inflammatory markers that are actually helping with healing right at the onset. The burn wound specialist may end up popping them when they see them in the clinic a day or two afterwards. But from our standpoint, it's pretty painful to pop blisters and to rip that off. So I would advocate, and you may do it differently, which is fine, because I'm not speaking from a position of amazing strength on this argument. But I would say, don't pop the blisters off the bat. Let someone else do it down the road. It can be a painful experience for folks. Next off, fluids. So we know when you get a big burn, you swell. Everything leaks. Capillaries leaks. Your body loses intravascular volume, goes extravascular. You get swelling. Usually about 8 to 12 hours is when that gets the worst. So we usually don't see the worst case scenario because we're seeing them usually in 1 to 5 hour increments or after the injury. Usually about 8 to 12 hours when this gets pretty terrible. So when do you give fluids to patients with burns? Typically the systemic response to burns will start at about 20% body surface area. So if you have under 20% body surface area, there's not a lot of literature that compels us as clinicians to provide an ample amount of IV fluids. Usually PO fluids are fine for 5 or 10% burns. If you're over 20% burn, that's when you should think about doing IV fluids. That's when it is more beneficial. What do you use? Ringer's lactate. I'm not going to get into an acid-base argument or discussion, but lactated Ringers have a nice, stable, and probably have some pharmacists that can expound on this a little bit more. But if you're going to use anything, use lactated Ringers initially. And colloids always come up. Only think about using things like colloid if your burn is close to half the patient's body. That's the only time you really need to think about colloids. So just stick with lactated Ringers and you'll be fine for fluid management. Don't forget about nutrition. Patients that have severe burns are nutritionally depleted. They're churning, they're catabolic, they're churning through energy, and you need to help subsidize that energy. So don't forget to put dextrose in your solutions. Patients need sugar in their solutions, especially early on in the process, especially kids, especially pediatrics. So what should guide me? That's my 14-year-old dog. Still with us. So what should guide me? Well, is anyone 75 years or older here? Come on. Nate? All right, well, none of you guys are alive. So Coconut Grove fire in Boston, 1942. All right, do you guys remember reading about this, hearing about this? So this is a pretty instrumental event in burn medicine. So this was in Boston. This was actually the night of the BC play. Holy Cross. Yeah, Holy Cross game. And they got their butts kicked, like 50 to 12. And BC was going to go to the Rose Bowl, and they didn't get an invitation. So anyway, they were supposed to have a big party for BC at the Coconut Grove that night. Didn't happen. It got canceled. So it was just a routine night. They can't call them nightclubs back then. It's post-prohibition era, so it was just like a dance or a revelry event. So they had a good sized crowd there, but it could have been even bigger. So there's some debate of how the fire started, and a few people ended up going to jail for this. But long story short is 490 people died. So there's over 600 casualties, and the Boston hospital system was inundated with major burns, something that they had never seen to that point before. And there was a medical student there that was actually given a patient that was deemed to be non-survivable. And at that point, 40 to 50% burns were deemed to be non-survivable. And that medical student was given this patient, didn't really know what they were doing, like none of us would, and actually used some parameters like physical exam findings as well as urinary output to help guide how much fluid to give the patient. So by using urine output, this medical student actually gave about this equivalent of the Parkland formula in terms of fluids to this patient. Now, mind you, the Parkland formula wasn't even invented until the 1950s, early 1950s. So this medical student gave exceptional care, and this patient ended up surviving by just using physical exam findings and urine output alone. This is especially true. Remember, at the onset, people usually don't think about it. They kind of get angry right at the beginning. So from our standpoint, using urine output in the emergency department isn't going to be beneficial. But if you're seeing patients 4 to 8 to 12 to 16 hours when they start switching into making urine, it's a really effective tool. From talking to trauma surgeons on this topic about fluids, they told to a T, each one of them told me, just don't give darn boluses to patients. They said set a rate, whether it's 500 an hour, 400 an hour. From an emergency standpoint, just set a rate. Don't drown patients in fluid off the bat. So that would be my take home for you. Try to avoid doing big boluses in these patients. Set a rate, leave it at a rate, and let the patient get cared for within it. These are some scenarios where you can have individualized needs that are a bit higher than usual. Electrical burns in particular. Okay, lastly, just a few things on logistics. We're going to be senders. What do we send? Kind of a hazy gray area. Most adults, it's greater than 10%. Pediatrics, less than, or a little bit other than 5%. Also think about circumferential burns. We discussed that before. Those are the patients you're typically going to send. Now, how do you guys, most of you folks are Vermont, how do you guys manage in terms of your sending patients? Do you send all the way down to Boston? Typically? And is that a tedious or difficult process? Not typically. Great. As you know, most burn centers are very happy to help with this situation, so don't be bashful in terms of calling. I've had to call before. They're very receptive to taking these patients. They know that they're the best, most qualified people to do so. They also have the wound specialists to do so as well. A good rule of thumb, I always like things that you can teach patients or teach patients' families. So a good rule of thumb is that if the patient's burn surface area plus their age is greater than 100, their chances of an adequate good survival is exceedingly low. So age plus body surface greater than 100 precipitously drops their or increases their mortality risk. One additional factor is the legal aspect, something we hate to talk about. I'd say this just in this regard, in children, don't forget about non-accidental trauma, especially scalding injuries. Most parents, especially if they're innocent, as you know, are very fine with that idea of evaluating that fully. So don't have a fairly quick trigger in terms of talking to your specialist around in terms of getting DHS involved, especially in pediatric burn patients. And then lastly, in the age of EPIC and documentation and taking pictures, I think that taking a picture and putting it in the chart, which is something we can do now at Maine Med, and I'm not sure if you can do it in your spot, but if you can do that in any way, and if you can't now, you probably will in the next 5 to 10 years, taking a picture of the initial burn is really helpful for folks down the road. Burns usually get worse in terms of their appearance at like day 3. So if you have kind of a landmark or a benchmark that you're evaluating, and a wound specialist can look 3 days previously and see what the burn looked like, it gives them a nice idea as if there's an infection going on, is this getting worse or getting better. So taking a picture of the burn, putting it in a chart or in some fashion, if not, you're not doing it already, think about doing it in the future. So feel the burn, okay? Fluids, evaluation, environment, and logistics.